If you're planning to do a frozen embryo transfer, you are going to want to watch this video first. You may not realize that there are different protocols to get the uterine lining ready to accept the embryo. And I want you to be able to understand it and advocate for your care, be able to ask questions and find the right protocol for you. Let's get started. I'm Dr. Laura Shaheen. I'm a double board certified OBGYN and reproductive endocrinologist practicing for over 20 years, and I love educating. I'm so glad you found this channel. If it's your first time here, welcome. Be sure to follow, subscribe, so you get my weekly videos all about reproductive health. If you're coming back to the channel, welcome back. I'm so glad you found this valuable information. There are two other ways to stay in touch. Number one, I have a weekly newsletter where I go over fertility events in the news. I link to current educational content, and I give you some product recommendations or books that I recommend. I really love helping you find resources. The second way to stay in touch is my weekly Baby or Bust fertility podcast. I interview experts in the field, fertility warriors, and sometimes do a deep dive into topics and share lots of valuable information. You can listen anywhere you listen to podcasts. But today we're going to be talking all about frozen embryo transfer protocols. Frozen embryo transfers are common. In my practice, it's more common to transfer a frozen embryo than a fresh embryo transfer. And there are different protocols to get the uterine lining ready to get pregnant. And so I talk to my patients every single day about the different protocols and help them understand which one is right for them. And today I want you to get that valuable information. In this video, we're going to go over 5 main topics. Number one, we're going to review the basics of a frozen embryo transfer and what the goal is and how we get there. Topic number 2, we're going to go over the basics of the 2 main protocols. There's a programmed or medicated frozen embryo transfer cycle versus the natural or ovulatory frozen embryo transfer cycle. And I want you to understand the basics of the difference. Topic number 3, we're going to go over the details of a programmed or medicated frozen embryo transfer protocol. Topic number 4, we'll go over the details of the natural or ovulatory frozen embryo transfer protocol. And topic number 5, we're going to go over the pros and cons of both. Stick around to the end of the video where I give you my top questions that you can ask your doctor to find the right protocol for you. Topic number 1, let's go over the basics of a frozen embryo transfer protocol. In general, we're trying to get the uterine lining to match when the embryo was frozen. Most embryos are frozen at the blastocyst stage. This is about day 5, 6, or sometimes even 7 after the egg retrieval. If you think about the IVF cycle, it's basically a menstrual cycle. It's about 2 weeks to stimulate the ovaries to get to the point where you can do an egg retrieval that's like ovulation. And then about 5 days later, that is when an embryo would typically come down and implant into the uterine cavity. But if you're not doing a fresh embryo transfer, which means 5 days after the egg retrieval, and you're doing a frozen embryo transfer cycle in the future, you want to prepare the uterine lining to match when the embryos were frozen. So we are trying to get the uterine lining to look like it should in a cycle about 5 or 6 days after ovulation or after the egg retrieval. And in a natural cycle, and this also happens in an IV. Topic number 2, we're going to go over the basics of the 2 main protocols. There's a programmed or medicated frozen embryo transfer cycle versus the natural or ovulatory frozen embryo transfer cycle. And I want you to understand the basics of the difference. On exposure, that is when the embryo implants. Now, there's a little bit of variety in this, and I will often say 5 or 6 days or even 7, because every clinic has slightly different protocols of when they freeze the embryos, how many days of progesterone exposure they do for the frozen embryo transfer cycle. So when I give variability, you need to talk to your clinic and your doctor about your personal situation. So I don't mean to not be precise. I'm trying to say that there's sometimes a little bit of variation. And I just want to get the basics and help you understand more so that when you are getting ready to get pregnant with your frozen embryo, you understand what's going on. Think about it like the embryo and the uterine lining need to fit together like a jigsaw puzzle. And if the uterine lining has seen way too many days of progesterone, that embryo is not going to fit like a jigsaw puzzle. Or if the uterine lining hasn't seen very much progesterone and you're trying to do a transfer only after a day or 2 of progesterone exposure, it's not going to fit. And so we have figured this out over almost 50 years of fertility treatments and many decades of frozen embryo transfer cycles. So the timing is well understood, and protocols, although they vary slightly from clinic to clinic, in general, it's pretty much the same if you're thinking about the overall concept of basics of getting the embryo to match the uterine lining. Topic number 2, the overview of the 2 basic types of frozen embryo transfer protocols: programmed medicated versus natural or ovulatory. Now, with the program or medicated cycle, the clinic or the doctor, me, your doctor, is giving your body estrogen and progesterone. And the ovaries are quiet. They are not ovulating. And we are giving estrogen until the uterine lining is ready. And then we're giving progesterone, and then we're thawing the embryo and doing the transfer. In the natural or ovulatory frozen embryo transfer protocol, your ovaries are ovulating. They are working, and the estrogen that your uterus is seeing is coming from the ovaries, and the progesterone that your ovaries are making is also helping that uterine lining develop. We often give a little bit of extra progesterone as a supplement, but your ovaries are ovulating. And those are the different types of protocols. The programmed or medicated cycle has been around for decades. And this is what I have been using for as long as I've been doing fertility treatments, which is now almost 20 years. The ovulatory or the natural frozen embryo transfer protocol is newer. The programmed or medicated cycle has been around for decades. And this is what I have been using for as long as I've been doing fertility treatments, which is now almost 20 years. The ovulatory or the natural frozen embryo transfer protocol is newer to me, or newer in the field. And it's an option that a lot of people like, but there's pros and cons to each of these options. And progesterone. And the clinic or the doctor is prescribing what's needed, like estrogen and progesterone. And the reason I call it programmed or a medicated cycle is because it is very predictable and very programmed. A typical sort of way that it gets started is when someone starts a period, they'll actually start taking birth control pills. That'll help keep the ovaries nice and quiet. Sometimes you'll overlap the birth control pills with a little subcutaneous shot called Lupron or Leuprolide that will also decrease the risk of the ovaries ovulating or being active in the cycle. We're actually trying to keep the ovaries quiet. If someone ovulates in the middle of their programmed, frozen embryo transfer protocol, then they'll start seeing progesterone too early, and we'll actually not do the transfer. We'll just stop and restart later. But you're usually kind of getting ready, keeping the ovaries nice and quiet. And then when everything's ready, you stop the birth control pills. You might shed a little bit of the lining of the uterus is there. And then you'll build up the uterine lining with estrogen. And estrogen comes in multiple forms. Some clinics give it with pills, like oral estrogen. Other clinics give it with patches, so estrogen patches that get changed every couple of days. And then there is intramuscular estrogen, which can also be used to build up that uterine lining. There's pros and cons to the different forms of estrogen. But remember, ovaries are quiet. And in this programmed or medicated protocol, we're giving estrogen. So it could be oral pills, patches on the skin, or intramuscular shots. Then, when the uterine lining is ready, and we usually figure this out with an ultrasound, transvaginal ultrasound, often called Wanda in our fertility community, because you really get to know her through all these treatments, can really get a good look at the uterine lining, make sure it's nice and thick, it's got a beautiful pattern, ready to go. And then when that's ready, you figure out when the transfer is going to be, and you start progesterone about 6 days. Every clinic has a little bit of a different variation, but about 6 days before the transfer, you start doing progesterone. Now, there is different forms of progesterone delivery as well. There's intramuscular progesterone shots. There is vaginal progesterone suppositories. It can come like Crenone is a brand where it's placed in the vagina. There's Endometrium, which is a different brand. These come with little applicators. And also sometimes you can get suppositories from a compounding pharmacy, or sometimes people even use pills and place it vaginally. So a vaginal delivery system, or even oral progesterone. Now, in programmed medicated cycles, the evidence really supports intramuscular progesterone shots. We've tried so hard through the years to try to get away from those intramuscular progesterone shots because it can be uncomfortable for people, and it's usually a daily shot. But vaginal delivery only was associated with a lower pregnancy rate. And so in my clinic, we are recognizing the evidence, and if someone's doing a programmed or medicated cycle, we've really got to start off with the intramuscular shots. Now, in my clinic, we will sometimes switch to a different delivery system, like a vaginal progesterone support, once the pregnancy is established, or we work with patients if they're really having trouble with those intramuscular shots, we figure something out. But in general, with the programmed medicated cycle, it is kind of predictable. It's usually down-regulating the ovaries with birth control pills and a little bit of Lupron. Then you build up the uterine lining with estrogen. I think of estrogen as the bricks that kind of build up this nice thick lining. When that brick wall is ready, you give progesterone. Progesterone is like the mortar in between the bricks, and it helps keep them together and solid. And then you do the embryo transfer. In our clinic, we usually stop the Lupron shots if we're giving it. We don't always give it. There's lots of variation. We stop the Lupron shots if you're taking them when we start the progesterone shots. And something that's important to know is that you continue estrogen and progesterone in a frozen embryo transfer cycle through the first trimester. When you stop differs, again, with different protocols. But because the ovaries are quiet, they're not ovulating, the ovaries are not making estrogen and progesterone, you need estrogen and progesterone from an outside source until the placenta starts making its own estrogen and progesterone, which typically happens around 8 weeks of gestation, but very often clinics will extend the progesterone and estrogen support just to really make sure everything is absolutely okay. Topic number 4, details of a natural or an ovulatory frozen embryo transfer cycle. Now, this is an option that has really developed over my career as fertility doctor and reproductive endocrinologist. When I started, or when I was doing my frozen embryo transfers, this protocol was not available, and it's something that has become more and more common throughout the years. And a lot of that is patient desire to decrease the amount of medications, patient desire to not have those intramuscular progesterone shots for weeks and weeks and weeks. I did them, and I get it. You'll most often hear this protocol referred to as a natural frozen embryo transfer cycle. That confuses me. Some of my patients get confused. I like to call it an ovulatory cycle because what's happening is in this protocol, your ovaries are ovulating, and in the other option, or the programmed or medicated cycle, ovaries are quiet. They are not ovulating. So that really tells me what's going on. It helps teach the patients a little bit. When you say natural, I don't know, it's just got such a negative term. There's already just, anyway, this is probably my thing, but there's just so much shame kind of built up in the inability to get pregnant naturally or have your body do what it's supposed to do. And natural just is just such a marketing term. It's like means different things to different people. And in my clinic, we still often use a little bit of medication here or there in the ovulatory frozen embryo transfer cycle. So if we call it natural versus medicated, and then we give some medicated in this ovulatory protocol, patients get confused. So that's why you'll hear me refer it as both. In this protocol, the ovaries are working. So we are watching a patient go through their own menstrual cycle, watching the uterine lining get thicker and thicker and thicker as it leads up to ovulation, watching the follicle, which holds the egg. It's that little ball of fluid within the ovaries. It gets bigger and bigger and bigger. And when the uterine lining looks beautiful, it's nice and thick, it's got a beautiful pattern, the follicle is mature, there's a mature egg in there, everything looks great. In my clinic, we typically give a trigger medication to trigger ovulation, and then we do the embryo transfer about 6 days later. And the patient is seeing estrogen from their own ovaries. We don't usually give extra estrogen, and their own ovaries are making progesterone. And we still give a little bit of progesterone. We just can't get away from it. I love it. It's the best immune modulator that our bodies can see. It shifts our immune system to a more receptive state. I love progesterone. And so we very often give a little bit of progesterone, but it's a lower dose than what we would use in a program cycle. Patients sometimes ask for intramuscular shots because that's easy once a day, but we typically will give a vaginal suppository as a way to support and give a little bit of a boost of progesterone in this natural or ovulatory frozen embryo transfer cycle. In my clinic, at least, there's a little bit of medication. Sometimes we even give a little bit of letrozole at the beginning of the cycle, like cycle day 3 through 7, just to help with that egg recruitment. And then we give a trigger shot, and then we sometimes give, progesterone as a little bit of a support, even though the ovaries are making their own estrogen and progesterone. That's the basics of the natural or ovulatory frozen embryo transfer protocol. And topic number 5, what are the pros and cons of these? Like, why would someone choose one over the other? Well, I talk to my patients that in my clinic, we don't see a dramatic difference in success rates as long as all the protocol and goals are followed. The programmed or medicated cycle is more predictable because you're usually, like with a period, you kind of know when you're coming in before you start estrogen, before you start progesterone, and then your embryo transfer. So it's usually pretty predictable, but it's more medication. With the natural or the ovulatory cycle, it is working with that person's body and menstrual cycle. And so it's less predictable. Sometimes it's more visits because we're trying to watch this development really closely. Sometimes you'll get frustrated because they ovulate before the uterine lining is ready. So there's a little bit of a higher chance of cancellation, which is totally fine for the embryos because we don't thaw the embryo until the morning of the transfer. But it's just emotionally disappointing when you are ready to get pregnant in a certain month and the cycle just doesn't want to agree with your schedule. And then we're like, nope, this is not the right cycle. Let's try again next month. So that can be very frustrating. Ovulatory natural cycle, less predictable, but also less medication. And so a lot of times, especially after someone's done stimulatory cycle with all those shots and they've recovered from the egg retrieval, they're like, I do not want to see more medication. I just kind of want to break from it. People have to be able to ovulate in order to do the ovulatory cycle. So for people with really irregular and unpredictable ovulation, the ovulatory cycle not a great choice for them. We have patients that are sometimes menopausal and they're conceiving with donor egg or donated embryo and they're not having cycles. So we have to give them estrogen and progesterone in order for their uterus to accept the embryo. So for that patient, an ovulatory cycle isn't going to be an option. As for everyone else, it's a really good discussion with the doctor, kind of looking at the pros and cons and have a very good discussion about what is right for that particular patient and their personal situation. I'm glad you stuck around to the end because now you've gotten an overview. And I know that there's differences kind of in each clinic and maybe each doctor or the delivery systems of the medication, but you've got the big picture that in general, there's 2 options: programmed, medicated, where ovaries aren't working and you're getting estrogen and progesterone from an outside source, versus ovulatory or natural protocol where the ovaries are working and they are making estrogen and progesterone. So the program is a little bit more predictable, but more medication. And the ovulatory is less predictable, but less medication. And you'll figure out the one that's right for you. But I'm glad, again, that you stuck around so I can give you some questions to ask your doctor. Question number 1, what options are available to me? There are some clinics that do not offer an ovulatory or a natural protocol, and that is just the right thing for that clinic. And so just, you got to ask, like, what is available, not only at the clinic, but also for your personal situation. So if you don't ovulate, an ovulatory cycle doesn't make a lot of sense. Also, if you live a plane ride away from the clinic, we have lots of patients that fly to Seattle to have their embryo transfers. An ovulatory cycle is just not feasible unless somebody wants to come and hang out in beautiful Seattle for a couple of weeks while we're doing the monitoring, just same day results and trying to coordinate that with two different clinics is really difficult, but talk to your doctor about what is available for you. Question number 2, do you have a recommendation for my personal situation? Don't be afraid to ask the doctor what they think. I think it's wonderful that this time in medicine, we're often giving options and sort of talking to patients about options and then giving the patient the option to kind of choose a path, but also your doctor's been doing this for a long time. They probably have an idea about what they would recommend for your personal situation. So it's okay to ask. Question number 3, why? Why do you recommend that for me? Get the answer. You should know. Question number 4, what is my next step? When can we get started? How do I get my questions answered? What do I do next? I hope you learned something today. I hope you found this valuable. Share this video with a friend that you know is getting ready to do a frozen embryo transfer cycle. It might really help clear up some confusion. If you learned something, like this video, comment with questions that you have, subscribe to this channel so you get my weekly videos all about reproductive health. And until next week, wishing you love, luck, and pineapples.